Hello, and welcome to Revive Health's Daily Briefing Live for Wednesday, May 27th, our 30-minute review of the latest, most important news, resources, and advice for health system marketers and communicators dealing with COVID-19. I'm Luke Farkas, your guest host for today's show, as Chris is out, and I'm joined here by Chase Kleckner, Senior Marketing Manager at Revive Health and our show's producer. Hey, Chase.
Luke, good to have you back again today.
I'm happy to be back. We're also joined today by Brandon Edwards, founder and CEO of Revive Health, and he brings just under 30 years of experience in healthcare and integrated marketing with a special expertise in issues management and the complexities inherent in the business of healthcare. Hey, Brandon.
Hey.
Good to have you here. So as with each show, we plan on covering the latest news on COVID-19 and how it relates to marketing and communications, and highlight helpful resources and share what we're seeing from a marketing communications perspective across the industry. And we'll open the floor to any questions as well. As we go through the show, feel free to put questions in the question and answer queue. There's also a chat function. You can interact with the other folks in this call, as well as any of our panelists as well. But if you'd like for us to answer any questions, please put that in the question and answer queue specifically. You can subscribe now to the podcast on iTunes, as well as on the podcast app if you have an Apple machine as well. So feel free to check that out. thinkrevivehealth.com/COVID-19 also has all of the latest resources that we're putting out as an agency related to COVID-19 and how that affects the marketing and communications landscape for hospitals and health systems. A couple important notes as we jump in today. We are not experts on COVID-19, so this is not a place for medical or scientific advice or resources. Hopefully that's obvious to this point, but in case it is not, we do, however, kind of have opinions on how marketers and communicators might want to manage the COVID-19 crisis, but everybody's situation is unique, and in the end, you have to make the decisions that are best for you and your market and your specific system. So with that behind us, I want to run through this intro pretty quickly today because we've got some really good content to get to. But we always highlight a few things at the top end of the show here. We have several different articles that will kind of frame the conversation, but we always start with a count of COVID-19 cases and deaths to help frame the discussion and to help us have something to track with how this pandemic is progressing. In the global count, I refreshed. We used the Johns Hopkins tool. I refreshed right before this show. We're at a global count of 5,626,047 cases. The death count in the world globally is 351,815. And specifically in the United States, the case count is 1,684,173. And the death count is nearing, again, that 100,000 mark at 99,123. So of course, we hate to keep seeing that number rise, but we're thankful for all of the medical professionals and clinical staff that are helping to keep that number as low as it possibly can be. So as we move on to the rest of the show here, there are two articles we wanted to highlight that broke kind of over the weekend and over the past week. The first is a CNBC piece that highlights some of what we're seeing in Louisiana related to some of what we'll talk about today. We know that there's a backlogged set of patients who are coming back in for surgeries right now, but what happens on the other end of kind of that pent-up demand. And then a similar piece, though more general, from New England Journal of Medicine Catalyst that really highlights what we're seeing and will frame some of this conversation as well. Chase just shared both of those links, so feel free to check that out. And we have just a few resources from our agency specifically. So in case you haven't seen it, we have a qualitative research report that we just put out in one of our biweekly reports recently. You can find it. It's the first, I think, option on thinkrevivehealth.com/COVID-19. We had 1 hour in-depth interviews with patients who either had their surgery rescheduled due to COVID-19 restrictions, or they need surgery kind of urgently today. And we asked them about some of their fears and concerns related to going back into a clinical setting. So feel free to check that out. And then just a reminder that we do send out kind of reports on the latest happenings in COVID-19 and how that affects marketers and communicators twice per week. Feel free to subscribe to that distro as well. All right, so we did tear through the intro here. Let's get started. We have Brandon on to talk today really about this phenomenon or this trend that we're seeing related to the missing domino. And I know that Chris has mentioned this idea in past shows, and we've talked kind of roughly about what that means, but we really want to dive into that today. So Brandon, can you give us some background on what the missing domino is and what it means for hospitals and hospital marketers?
Yeah, and to Luke, to that question too, we plan to post out a new blog either later today or tomorrow on this topic as well. So if you're new to the podcast, or if you're kind of scrambling to take notes or whatever, there will be some content that follows this as well as the normal recording. So I guess maybe it's helpful. Let's hit a little bit of rewind and look at when we first started thinking about rapid recovery a couple months ago. I guess it would have been not long after the initial shutdown and quarantine. We started thinking about what is planning for rapid recovery look like. And I think our focus at the time was almost entirely on the summer period, the period we're in now, really, where we had patients already scheduled who had not yet been canceled, as well as patients who had been put on pause for their elective or scheduled surgery. And so much of our focus was on ensuring that we were getting those patients back in quickly, that we were doubling up volume where we could, that rapid recovery was not just about locking in your losses, but was actually about really bringing back those patients that were able and willing, and driving as much recovery as fast as possible, particularly from those high margin elective and scheduled surgical procedures. I think what's become clear now, even in the month of May, so you figure the most aggressive hospital surgical scheduling started on May 1st, and that only happened in a few places around the country. Today, we're 26 days into that. What's clear, I think, seem to be a couple things. One, the percentage of patients that had been scheduled that went on pause that are coming back is lower than what everyone had expected. It's we could argue that 60% or 80% of January volume is a success. I would, I guess, argue that if I had told you in January that 20 to 40% of your surgeries were going to disappear, you would have been terrified for the implications for your hospital's finances. But this is where we are now. So I think, number one, there's clearly a constraint on demand. That is from loss of jobs, loss of insurance, reticence about missing work, fear of COVID in a healthcare setting. But this missing domino piece, I think, is something that's become a lot clearer to us over the last few weeks, is that if we work our way through the pent-up demand and we work our way through those patients that were already scheduled for May, June, maybe July, who's after that? And so there seems to be, what we mean by the missing domino here is that patients move through non-emergent patients move through a progression, right? They start out in a primary care setting, probably they're referred to a specialist, there's lab work or there's diagnostic imaging or perhaps a preventative screening, identify something, if it's oncology, lots of different things that could be the precursors to a higher margin surgical service. But the volume recovery that we're seeing constrained on the surgical side, we're also seeing on the non-surgical side. And so really what we're trying to focus on now is how do we fill back in that missing domino? If all the early dominoes fall and there's a missing one, there are surgical schedules later in the summer or in the fall are really at risk of being anemic. And that won't be because we can't handle them. That will be because there aren't enough patients to demand service. And it's because they haven't been in to see their specialist. They haven't had diagnostic imaging. They haven't had lab work. They haven't had whatever is necessary to get them to that point. So I guess we look at this really in two ways, right? There's a very real business imperative. There were huge drop-off in physician office visits and consults, and all the kind of stuff that we would see in referrals. Those are recovering, but at about the same rate as the deferred or paused volume, if you will, on the surgical side. So we think there's a financial imperative here, obviously, for hospitals and health systems to get these folks back in. There's also, I would argue, a moral imperative. We know that there are people who are desperately in need of care that are not getting it. And that is being borne out in all the statistics on drop DD volume. What does that mean for heart attacks, strokes, things like burst appendicitis that were pretty unusual. DOA rates from hospital or from ambulance transports are up in a lot of communities. So I think the sort of macro concern here is if we get rapid recovery right, we will help to restore some of the financial stability that hospitals and health systems need. But if we don't fill in this missing domino, there is a problem that will emerge late summer, early fall, maybe early winter at the latest, which, guess what, just happens to coincide with seasonal flu and likely COVID and the kind of concurrent emergence of those two things. So it's a lot to think about, but I think really that missing domino piece is all about, are we getting patients into the funnel, if you will, into the system in such a way that those who are going to need some more significant treatment and a higher margin service for the hospital are available for that in 60, 90, 120 days.
Yeah, that's great. And I think that the next question I was going to ask is really focused on, the media and different players, us included, have done our fair share of highlighting the importance really of high margin services and surgeries and elective surgeries. But we're talking about lower acuity services on this podcast. And I think you talked about some of why, but do you want to add anything to that around what is it, what are those likely lower acuity services? And how does that affect kind of the future of elective surgery?
Yeah, I think I got to give Chris Bevelo credit for this, and it pains me to do that, although it's better that he's not on the podcast. He's been talking about this since I very first brought up the idea of rapid recovery to him. And at the time, I'm the one that pressed back saying, I'm just not sure about that. Like if you can only do a few things well, we've got to focus on those high margin services. We've got to focus on the operational side. And I think there was more than a part of me. I think I believed that lower acuity volume would come back, that people would return to vaccinating their kids and coming in for well baby checks and, coming in to see their primary care doc or, honoring the referrals to an orthopedist or a neurologist or an oncologist, or whoever it was. And it seems pretty clear now after just a few short weeks that that's not going to happen, at least not immediately. And so, there's more than one way to get at this problem. But I think it's now very clear that rapid recovery that's only focused on surgical volume is going to solve a short-term problem. It's still a very important short-term problem, but it is not going to solve the longer-term volume of getting people back in those other services that they need, some of which will lead to higher margin surgical volume or other kinds of treatment.
Right. There seems to be also sort of an inverse relationship between the acuity of services and the degree to which fear even matters in the consumer decision-making, process. You have obviously these higher acuity things that we have referred to as sort of the pent-up demand, where many people are returning to settings, and that's where we're seeing these kind of maybe 60 to 80% return on surgical volumes right now. But there's this real concern on the lower acuity side of things where a little bit of fear might go a long way in whether people even seek out care.
I think that's actually really the way you just said, that's very intuitive too, right? That if something's really wrong, you may overcome your fear.
Right.
If it is sort of normal or routine care, you may not feel compelled to. And I think we're even seeing on the front end of that it's not helping people overcome their fears. Right? If you're self-diagnosing a heart attack or a stroke, like stop and go to the hospital, right? Like this.
Yeah.
That is not for an amateur. That is for professionals, and that's true for all kinds of different conditions. But to your point, you're seeing people defer all sorts of care, and we've talked about some of the factors around that, insurance and jobs and all kinds of things. Don't want to diminish that,
Yeah.
but it means people are not getting healthcare they desperately need. And I want to believe that it is going to sort of restore some sense of normalcy. That said, am I convinced of that? Not really. And I just had mentioned to Chris a couple of days ago, we were talking to CFO of one of the largest nonprofit health systems in the country a couple of weeks ago. And I was sort of pressure testing a few ideas with them. And to his credit, he said, Brandon, I don't think any of us know any of that for sure. He said, we're 75, 80 days into this. To pretend that we know that the impact that this has had on human psychology and consumer decision-making in healthcare is probably a bit of a fallacy. And that was kind of one of those moments where I'm like, first of all, this guy's so much smarter than I am and so much more experienced than I am. But there was a humility in that of saying, we just don't know what we don't know. So right now, the thing I think we can focus on is rapid recovery to get people back in surgical suites, and significant acceleration in marketing and physician engagement that will lead to restoring consumer comfort with returning to a physician's office. We've got to get people into what is effectively the hospital's pipeline for services.
Right. Yeah, and that's that missing domino. And I can imagine, marketers or listeners here asking kind of this question, like, sure, guys, like, I get this in theory, I get the missing domino, but we're having a hard time tracking. I mean, we were having a hard time tracking the patient journey before COVID hit, much less after, in this kind of chaos that is kind of post-COVID era. How do I know which top of the funnel services to highlight now to secure kind of surgeries in late 2020 or even into 2021? I mean, do you have any thoughts about that? What kind of those higher level funnel services might be for some folks?
Yeah, I mean, I guess it's also fair to note that if you do nothing, you won't have to worry about measuring.
Sure.
So we know for sure that doing nothing will require no measurement of any kind.
You heard it here first, folks.
It is a fair question, though, right? Yeah. And so I think what's difficult about it is it totally depends on the hospital and health system and what services they're trying to generate. Is it orthopedics? Is it neurology? Is it oncology?
Right.
It's going to be one of the big, 3 or 4, cardiology, that are likely to drive the greatest margin. What are the upstream services from that? So I actually think that it might be a mistake to start at the very top of the funnel, but instead starting at the part of the funnel, if you will, that's just before surgery. So who's had a referral to a specialist who hasn't had that appointment fulfilled? Who's had an appointment with a specialist but hasn't had their diagnostic imaging or their labs done?
Sure.
Right? Who's has preventative screenings that were scheduled, particularly women for cancer and men for cancer, that haven't been fulfilled? So you almost look at those people in the same way that you think about pent-up demand on the surgical side. Think about pent-up demand on the pre-surgical side. What are those things that are most likely to produce needed care and patients for that needed care in 60 to 90 to 120 days? And then I think you can kind of work your way up the funnel. So the things that are probably the least likely to capture direct linkage are things like urgent care visits or lower acuity telehealth visits. Again, I'm not saying don't do them. I'm just saying in terms of what you're marketing, I mean, if the average hospital gets 50% of its admissions through the ED, the number one thing that we can do that gets people needed care is restore confidence in coming to the emergency room. Right? That's going to restore huge cash flow for the hospital, going to provide people with needed care. But we know that some percentage of those people are going to end up admitted or in surgical suites as well. So I think that's probably the most obvious spigot you could look at turning on. I think I would sort of look at those two things as really focusing on AD and the safety of the ED, and then focusing on those patients that were the closest to the end of the funnel for surgery and kind of working our way up. It's going to be different every place. We know that, right? There is no one answer. There is just a thought process that gets you to that answer, I think.
Yeah, and to that point of there not being one answer, this is possibly an impossible question right now. But if we look at the kind of attracting folks to the ED, or convincing them that it's a safe place to go to for the care that they need, is the better way to say that. Are there elements that, hospital marketers should be aware of, messaging things to highlight? Like, what are the likely things that might bring folks to a confidence level where they start consuming emergent healthcare in a similar way as they did prior to COVID-19?
Yeah, we've speculated about this. So sorry, let me focus on your messaging question, and then
Sure.
I'll talk a little bit about sort of ED, urgent care, telehealth, convergence. I think here's the good news. Much of the messaging that we needed to share with patients to make them comfortable coming back to a surgical suite is the kind of messaging that we need to share with consumers to make them comfortable coming back to anything.
Right.
It's about safety. It's about cleanliness. It's about protocols. It's about testing. It's about all the things that say, look, we've got you, right? We've got you taken care of here. And here's all the things we're doing to ensure that you are safe and going to be safe and healthy in our care. And making it about them, not about us, right? We're meeting them where they are in their fears, whether we think they are irrational or not. I was talking to somebody last week in a hospital executive role who said, we know what we're doing here. They just need to trust us. And I said, with all due respect, I don't think that's the attitude that you want to take about this, right? It hasn't totally looked like we know what we're doing for the last 3 or 4 months. Sure. And granted, it's a crisis and a bit of an unprecedented crisis, but you only get that hall pass once. You don't get that hall pass 2 or 3 times. So I think we have to meet people in their fears and their anxiety about this. We have to alleviate those as factually and emotionally as we can, right? Where those things converge. But I think that beyond that, I think there's an opportunity to be substantially more personalized. So when we talked about sort of working our way up from the bottom of the funnel, we know who those people are. In the same way that we knew who those surgical patients that went on pause, we know them. We know who they are. We know what they need. We know that someone who has gone to a primary care doctor, been referred to an orthopedist, and is awaiting an MRI, we know who they are. We know what their issue is. How do we streamline that process for them, reassure them, again, meet them where they are from a messaging standpoint? I worry a little bit that what I said about ED could be misconstrued. I am not suggesting that we need to push people into the ED.
Sure.
I want to be really, really clear about that. If we've talked a lot about with recent guests on podcasts about, is it maybe finally that the right volume is going to the ED, and the volume that should have been in an urgent care setting is finally in an urgent care setting, and the volume that should have been in telehealth all these years is finally in telehealth. There is some truth to that. We also know from all the information that's coming from a number of sources, including New England Journal of Medicine, that there are people who should be in the ED who are not. That's who I'm talking about. I just want to be really clear. It's removing the barrier to care, which is really a fear barrier at this point. Ironically enough, less of a financial barrier in the ED, right? The financial barrier may be more for elective or otherwise, but that ED is one of the few places that you actually know what you're going to pay when you walk in. So it's, from that standpoint, there's probably less of a fear of financial obstacle involved.
Right. Okay, so just a reminder for listeners, if you have any questions, feel free to put that in the Q&A. We might be able to hit those right before the 12:30 mark. But I do have kind of one kind of sum up question for you, Brandon. So we've talked about a lot of this related to the missing domino. Do we have, what are the few key takeaways that we'd like for people to take away from it, just as marketers and communicators of hospitals and health systems here?
Yeah, I mean, I think there's maybe a couple things to focus on. So number one, I think, is if you are not already pursuing a rapid recovery strategy, operational and marketing working hand in hand, start right now. Start planning right now, start executing that right now. You may say, hey, we're fine. We're at 80%. I'm not worried about the marketing. Well, take a look at the schedule for 60 days from now and see what that looks like, or 75 days from now. And my guess is there's a big drop off that's going to happen probably right around August 1st to August 15th kind of a thing. I think, so if you're not doing that, that's got to be job one, because that's now stuff. And if you're not doing it and there's a first mover advantage in your market that is, you risk losing share to that player. Number two, I think, is really focusing on aggressive marketing and physician relations and physician engagement around reaching all of those patients that will eventually be surgical patients or eventually be patients in higher margin treatment services. And I think that that's going to have to be done very carefully with many of the same messages and touch that we talked about in rapid recovery. But we need people back in docs' offices. We need people back in EDs. We need people back in diagnostic imaging and getting lab work and getting the care that they need, again, from a financial standpoint and from a moral standpoint, I think from a mission standpoint. And then third, I would just offer is, I think you really have to start planning right now for what that fall winter is going to look like. If I have any great concern is if we don't get the first two right, we're going to have huge financial issues. But even if we get the first two right and we don't prepare properly for seasonal flu COVID resurgence, I worry that what the conclusion consumers and others will reach is that we're not competent to handle that problem. Right? The first time around, we were surprised by it, and then there was a great hustle to solve the problem. But you don't get to be surprised by the same event twice. So again, it's kind of three things: rapid recovery first, restoring that other volume second, back in docs' offices and diagnostics, and third is really preparing for the fall and winter so that we are not forced into another shutdown scenario, which I can't even imagine the financial implications for hospitals at that point.
All right. Thanks so much. I think that closes the show really well here. That's it for today's show. Please let us know if you'd like us to cover what you'd like us to cover in future episodes by posting in the chat tool here. Brandon, thanks so much for joining us.
Yep. Thanks.
Okay.
I appreciate you having me on.
Yeah, of course. Chase, as always, thank you.
Absolutely enjoyed the conversation. Thanks,
yeah.
Brandon.
A little preview to tomorrow's show. We have Sasha Bogosian joining us as guest host, along with Tiffany Pack, to talk about the strategies for health systems and how they should be implementing their strategies, as well as beginning new messaging and marketing activities as we progress forward with this virus. Remember, visit thinkrevivehealth.com/COVID-19 for a recording of today's episode and all of our content related to the crisis. There's always something new there. Subscribe on iTunes if you'd like, and please remember to let others know about this podcast if you're enjoying it. And we finish the show the same way every time, as a call to hospital marketers, to all you out there. Hang in there, keep up the amazing work. The skills that you bring as marketers and communicators are critical in helping us move past this crisis. We'll be back tomorrow and every weekday until this passes, and we'll talk to you all tomorrow.